Good evening. My name is Kelly Graves. I'm a student at Aspen University. The date is December 28, 2019. My presentation this evening is to prepare the clinicians in the emergency department for which I work an introduction to a new evidence-based research clinical guideline supporting the use of non-steroidal anti-inflammatory drugs for acute cholelithiasis, which is pain related to kidney stones, versus opioid administration for the same pain. Objectives for this presentation are as follows. Identify a clinical problem, assess critical appraisals, identify theoretical model, develop a strategic plan, identify operationalizing method, identify internal evidence to support my external evidence, develop evaluation method, and recognize any ethical considerations that might accompany this clinical guideline. The clinical problem is a community problem. What our establishment is trying to do is reduce unnecessary opioid use in our emergency department and hoping that it will extend outside the emergency department as well. Opioids are highly addictive. Opioid overdoses are claiming approximately 130 lives per day in the United States. Opioids are less effective, requiring additional dosing for treatment of renal colic. Therefore, why give them? Opioids have a greater number of side effects, and in Washington State, Snohomish County, where our hospital resides, has the highest number of opioid-related deaths. The research being supported in this presentation is the most effective treatment for pain related to the formation of stony concretions in the urinary tract, kidney stones, is proven to be non-steroidal anti-inflammatories versus the addictive opioids as the first line of treatment. Multiple critical appraisals of scholarly journals were performed and appraised for the application to renal colic related to urolithiasis as follows. The American Journal of Emergency Medicine twice, British Medical Journal, European Journal of Clinical Pharmacology, New England Journal of Medicine, Health and Medicine, Drugs, and the New England Journal of Medicine, all in support of our newly introduced clinical guideline for the treatment of pain related to urolithiasis. In preparation for this introduction, there were some ethical considerations that needed to be performed. Number one, pain is a subjective matter. Providers have an ethical obligation to treat pain within the limits of patient safety. The concern is that the potential of avoiding administering opioids even if the patient requests it or requires it, due to the dedication to accomplishing this introduction to the clinical guideline goal, it may be an interfering factor. So the solution to this is to treat pain management as a priority, demonstrating respect for that human person regardless of clinical guidelines. Expertise will guide and allow clinicians to detour from the guideline if needed for the best patient. In order to present a case, you need a theoretical model to follow. I chose evidence-based process model. This model it provides a relentless guidance in the preparation and the execution of the implementation process systematically to reach a set goal. It identifies and utilizes phases in the process, translating research into practice. It guides the process of translating research into practice with the use of specific strategies, executes the use of research, such as non-steroidal anti-inflammatories are more effective for pain control versus opioids as a first line of treatment. Evaluation. Do NSAIDs effectively control renal colic better and with fewer side effects than opioids? Strategic plan. Number one, you want to create awareness and interest from all of the stakeholders. You want to announce the implementation of clinical guideline for non-narcotic pain relief of kidney stones. Utilizing staff meetings, unit newsletters, and unit in-services to inform staff. You want to highlight the advantages supported by evidence-based research, and you want to highlight the potential impact on an opioid-saturated community. Creating slogans and logos, placing them in viewing areas, dispersing evidence-based resources such as the critical appraisals, posters, and flyers. Place them in ideal viewing areas of the participants. Provide access to the resources via the organization's intranet. Encourage management and administration to become involved in the unit campaign and being supportive of those that will be participating as clinicians. Providing educational outreach opportunities, completing skill competency reviews with clinicians, reminders and prompts appropriately placed throughout the work area, providing visual clinical guideline algorithms to the staff so they can view exactly how this process is going to work, and provide quick reference guides available at workstations. All of these will promote action of the process. As with any new clinical guideline, there are always a potential of barriers for implementation. Potential barriers in this case could be time constraints, minimizing the clinician's ability to concentrate on following clinical guidelines, organizations' resistance to follow evidence-based practice historically, indicating that maybe there's not a true support by administration. A clinician with a lack of buy-in creates a lack of knowledge and a lack of desire to carry out the new clinical guidelines. And the inability of clinicians to apply these findings, even if they believe in them, into daily practice. For some of those potential barriers, I offer some solutions. Time constraints. During the planning phase, arrange for clinicians who are assigned renal colic patients to have fewer patients. This may need to continue while new clinical guidelines become habit. Demonstrate patient benefits of applying these new guidelines, pain control without addiction and adverse side effect concerns. Share the positive healthcare outcomes of renal colic patients from critical reviews of evidence-based practice to accomplish buy-in. Now that buy-in by the participants has been achieved, it's time to adopt this plan. You want to assess the patient medical history. You want to screen every patient for signs and symptoms of renal colic. Generally speaking, a severe unilateral abdominal or flank pain is present with the renal colic. You want to collect a urine for occult blood. You want to collect blood for evaluation of renal function and possibility of infection. And you want to document pain scale 0 to 10 before administration of any NSAIDs. And then you want to administer the NSAID. Continuing on with the clinical guideline, the next is to perform an abdominal pelvic CT to determine a kidney stone, if there's no history already of a diagnosed kidney stone. Then you repeat your pain assessment at 30 minutes, 60 minutes, 90 minutes following the medication administration. Document any side effects, document the need for additional medications, what that medication was, how much of it, the effectiveness, and of any sort of adverse side effects. Now it's time to evaluate. You want to synthesize the results and you want to follow up. Unless clinical guidelines were followed 100% of the cases, evaluate any barriers and note any trends. Address specific interfering factors. Unless results were met, the goal in 100% of the cases, evaluate barriers and trends on that as well and address specific interfering factors. This evaluation method is accomplished by retrieving patient information on all the renal colic patients presenting to the emergency department from day 1 to day 30. You want to ask, was the renal calculi clinical guideline followed 100% of renal colic patients? Was the pain effectively controlled by NSAIDs as demonstrated utilizing a 1 to 10 pain scale? Did patients need opioids as secondary analgesia for pain control? Did patients have adverse effects from the NSAIDs? If patient required opioids in addition to NSAIDs, how has the patient been treated for renal colic or other pain with opioids in the past? Was a kidney stone actually confirmed? Continuing on with the evaluation, you must incorporate internal evidence as well. Internal evidence such as the patient history assessment data, patient physical assessment data, allergies, vital signs, lab results, pain scale results. You want to look at the patient's socio-demographic factors. You want to look at outcome results, analgesia needs, opioid administration, adverse effects. You also will incorporate professional expertise and patient preference and values. With all of this information gathered, it's now time to celebrate. You want to celebrate the first round of the renal colic pain control evidence-based practice clinical guideline application. And you also want to celebrate the fact that you're beginning round 2 with modifications as indicated by the round 1's evaluation results. Thank you so much for your time.